Hello friends, my name is Dr. Shailesh Gupta. I'm a laparoscopic bariatric and robotic surgeon at Max Perkins Hospital, Delhi. So I welcome you all to our new series of lecture, that is Mastering Bailey Insufficiency page by page, in which we are covering these two textbook page by page, line by line, emphasizing on the main points and also simplifying the text. Along with that, we are objectively covering the text, figures and boxes. So it is a very important for MS General Studies students and also important for NEET SS aspirant. So today I am going to present second lecture of this series, that is Metabolic Response to Injury Part 2. Part 1 we covered on the Friday. So this is a pre-recorded video and at the end of it I will come live for question and answer session, and in between you can write your question in the chat box. I will be happy to answer them at the end. So as I told you in the first lecture, my lecture is centered around this. I have simplified the text page by page and emphasized the important points, and also I have covered the figure, table and boxes objectively. So before starting the theory, there will be some MCQs in the form of pre-test, the purpose of which is to generate the interest and focus so that at the time of text you will be more attentive, right? The answer of this pre-test will be given in the post-test formally, and also you can find the answer in the text. Again, I just want to emphasize that this is not a MCQs based question. This is basically we are covering the standard textbook page by page. So what is the content of our lecture? Content of lecture are following. Today I am going to cover key catabolic element of the flow phase of the metabolic response, which is alteration in the skeletal muscle protein metabolism, acute phase protein response, insulin resistance. Also I am going to cover changes in the body composition following injury, and I am also going to discuss avoidable factors that compound the response to injury, which are volume loss, tissue edema, hypothermia, immobility, starvation, systemic inflammation and tissue underperfusion, and in the end we also going to discuss about ERAS protocol. So the first topic is alteration in skeletal muscle protein metabolism, which happen in catabolic phase of stress response. So these are some MCQs which you can find, the answer of which you will find in the text and also in the post test. The first question is, in extreme catabolism, what is the equivalent loss of skeletal muscle per day? 250 gram, 500 gram, 750 or 1000 gram. Second question is, what is the main site of protein loss during the catabolic phase of the stress response? Cardiac muscle, respiratory muscle, peripheral skeletal muscle and gut muscle. Question number 3, what is the turnover rate of muscle protein in the human per day? 0.5 to 1%, 1 to 2%, 2 to 3% and 3 to 4%. Question number 4, what is the main mechanism responsible for the wasting of skeletal muscle? Lyosome cathepsin, calcium calpain pathway, ATP dependent ubiquitin proteasome pathway and glycolytic pathway. So guys, now we start with the text. I am going to first discuss the normal physiology of the muscle protein. It is seen that in the muscle protein there is a continuous synthesis and the breakdown, and there is a turnover rate of 1 to 2% per day. Diurnal changes are more in the synthesis as compared to the breakdown, and the synthesis of the muscle protein is equal to breakdown. That is why constant bulk is maintained, right? So it is seen that there are two factors which promote the muscle protein accretion. Number 1, feeding of amino acid, and number 2, exercise. There is a paradox which is seen in the exercise, which means that muscle protein synthesis is more while doing rest and it is depressed while doing exercise. That is why in the workout the rest period is very important, because at this rest period the muscle protein synthesis get increased. So please remember this paradox, right? So in catabolism muscle wasting happened, it is very obvious. So it happened by increased degradation via enzymatic pathway and happened by decreased synthesis. So primary site of protein loss is skeletal muscle, peripheral skeletal muscle, and it also impact the respiratory muscle and gut. So in the respiratory muscle, it will going to cause hypoventilation, and it also going to cause chest infection like pneumonia. In gut, it will lead to reduce gut mobility. Right? So remember this point, and most important, cardiac muscle is spared. So cardiac muscles are not impacted by the catabolic muscle wasting. So moving on, it is seen that in the major sepsis, the urinary nitrogen losses may reach up to 14 to 20 gram per day, which is quite a high amount. And this 14 to 20 gram per day loss of nitrogen is equal to the loss of 500 gram of skeletal muscle per day. So this is a huge amount, right? So hyperalimentation. Hyperalimentation is a TPN. So this is a very commonly seen practice in our clinical day. So in lot of critical ill patients, we give TPN, that is total parenteral nutrition. So it is known that TPN causes oxidative stress. So the nutrition you are providing in the form of TPN itself is a metabolic stress, right? This is a very important point to emphasize. So that is why the enteral feed is very important, right? TPN can't replace enteral feed. TPN is source of a stress. And it is also important to know that the role of TPN should not to fully replace the losses, but to attenuate it. And the cause is because it causes oxidative stress. So we don't want to give in a higher volume, right? So there is a term known as critical illness myopathy. Please remember this, critical illness myopathy. Critical illness myopathy is basically a myopathy which happens at critical illness, and it impairs the excitation contraction coupling in the muscle. So it leads to myopathy. So along with the muscle wasting, myopathy also happen. So please remember the critical illness myopathy, right? So this is a figure which is taken from the Love and Bailey, and it shows the mechanism of skeletal muscle breakdown or skeletal muscle wasting. It happened by the ATP dependent ubiquitin proteasome pathway. Please remember the name of this pathway, it is very important. So what is happening in this pathway? The myofibrillar protein is getting combined with ubiquitin, right? And this is a ATP dependence process. So once this protein get combined with the muscle, it is seen that it becomes very vulnerable to get degraded with the 26 proteasome. This degradation is also ATP dependent process. So by 26 proteasome, this combination of ubiquitinated protein get broken down into the amino acid. So this is how the catabolism breaks the skeletal muscle. So now the post-test, you're going to get the answer of the pre-test in this. So answer of the question number 1 is 500 gram. During extreme catabolism, example major sepsis, the equivalent loss of skeletal muscle per day is 500 gram. And the second question was, what is the main site of protein loss during the catabolic phase of stress response? Answer is peripheral skeletal muscle. Please remember, cardiac muscles are spared, right? Please remember this. Question number 3, what is the turnover rate of muscle protein in human per day? Answer is 1 to 2%. What is the main mechanism responsible for wasting of skeletal muscle? We just discussed in the last slide, ATP dependent ubiquitin proteasome pathway, right? So now the next topic is alteration in the hepatic protein metabolism, that is acute phase protein response of stress. So pre-test, I would request the students they can write the answer in the chat box. So this will make the lecture more interactive. So question number 1, what is the percentage of daily body protein turnover is contributed by the liver and skeletal muscle combined? Less than 25%, approximately 30%, over 50%, around 40%. Question number 2, how does the transcapillary escape rate, that is TER, of albumin compare to its synthesis rate? Is equal to synthesis rate, twice the synthesis rate, 10 times the rate, and half the synthesis rate. Question number 3, which cytokine plays a main role in promoting the hepatic synthesis of positive acute phase protein? IL-1, IL-6, TNF-alpha, and IL-10. Question number 4. How much may albumin TER increases following major injury or sepsis? 2-fold, 3-fold, 4 or 5-fold. So now I am going to discuss about acute phase protein response theoretically. So I am going to discuss first about normal physiology. Liver and skeletal muscle contribute 50% of the total body protein turnover. This is very important, right? It is seen that skeletal muscle, despite of its larger mass of 4 kg, only contribute 1 to 2%, whereas liver being little smaller, it contribute 10 to 20% per day of turnover of protein, right? And it is important to know that there is an equal synthesis of structure and export protein in liver. So example of structural protein is basically, example is collagen, right? And export protein is albumin. So both type of protein are synthesized in equal amount, right? Just remember that. So it is important to know that albumin get renewed at the rate of 10% per day, and the transcapillary escape rate, that is TER, of albumin is 10 times the synthesis. This is a very important point. And short-term changes in albumin concentration is due to the increase in vascular permeability. And following major injury sepsis, albumin escape increased by 3-fold. So remember these 3 points. Normally, the escape of albumin is 10 times the synthesis, and in case of the major injury sepsis, this escape increased by 3-fold. So it is seen that in case of injury, sepsis or trauma, pro-inflammatory cytokine get released, that is IL-1, 6, 8 and TNF alpha, and out of which the IL-6 is the main factor which leads to formation of hepatic synthesis of positive acute phase protein. And example of acute phase protein are fibrinogen and CRP. These both are example of positive acute phase protein, right? Example of positive acute phase protein. And the main factor is IL-6. IL-6 leads to hepatic synthesis of positive APPB in response of injury, sepsis or trauma. So guys, it is important to know that acute phase response is very important for a immediate survival, but it depletes the valuable energy resource. So it is a double-edged sword. So it is seen that in acute phase protein response, negative acute phase reactant such as albumin decreases, right? This decrease happen due to increase in the escape, due to increase in the transcapillary escape or increase in the microvascular permeability, but their synthesis remain normal, right? So in acute, to summarize, in acute phase protein response, negative acute phase reactant decreases. You remember negative, so it will decrease. But decrease happen because of the increase in escape. The synthesis is happening at the normal rate, right? So to move on, the next slide, this is summary. Positive reactant increases like CRP and fibrinogen, and negative reactant like albumin get decreases. So now the question of the pre-test. Question number 1 answer is over 50%. Combined turnover of liver and skeletal muscle is more than 50%. How does a TER of albumin compared to synthesis? Is 10 times the synthesis rate. Question number 3. Which cytokines plays a main role in promoting the hepatic synthesis of positive acute phase protein? Answer is IL-6, and acute phase protein example is fibrinogen and CRP, right? Remember this. By how much albumin TER increases following major injury sepsis? Answer is 3-fold. So the next topic I will discuss insulin resistance during the catabolic phase. So the pre-test, what is the reason of insulin resistance in the stress patient? Increased responsiveness of insulin regulated proteins, increased action of pro-inflammatory cytokines only, decreased responsiveness of insulin regulated protein only, and choice number D, action of pro-inflammatory cytokines and decreased responsiveness of insulin regulated glucose transport proteins. So following injury, hyperglycemia occurred due to increased production and decreased uptake, right? And this decreased uptake in the peripheral tissue is known as transient insulin resistance. So what is the reason of transient insulin resistance? The answer is increase in the pro-inflammatory cytokines and decrease responsiveness of insulin regulated glucose transport proteins. This happening at the receptor level of peripheral tissue, right? So inflammatory cytokines are also increased, and there is a decrease at the level of insulin regulated glucose transport proteins. So these patients behave typical to type 2 diabetes mellitus requiring intravenous infusion, and extent of insulin resistance is directly proportional to the severity of injury. This is same as graded nature of injury that we discussed in the previous lecture. So the answer of question number 1 is action of pro-inflammatory cytokines and decreased responsiveness of insulin regulated glucose transport protein is the reason of insulin resistance, right? Both the things are important. So now the next topic is changes in the body composition following injury or stress. So guys, this is a pre-test. What is a primary labile energy reserve in the body? Protein, carbohydrate, fat or mineral. Question number 2, what is the average weight of the fat in the 70 kg male? 13 kg, 15 kg, 70 kg, 42 kg. I would request to the students they can type the answer in the chat box and make this class a little interactive. So question number 3, at what percentage of total protein loss does survival become unlikely? 10 to 20%, 20 to 30%, 30 to 40%, 40 to 50%. How much weight of lean tissue is equivalent to the breakdown of 1 gram of nitrogen in urine? 24, 36 gram, 48 gram, 60 gram. So here you can see there is a lot of stat in these MCQs, but these answer of these are clearly given in the line of Bailey, and that is the whole purpose of this lecture, to bring those hidden line to you so that it becomes simple to learn and remember, and you can answer in the exam. So this is a basically a figure of 70 kg average male. So here we can see that fat is of 13 kgs. So the amount which is left after the subtracting the fat is fat free mass or lean body mass. So lean body mass is the amount or is a weight which excludes fat. So lean body mass contains protein. Protein is of around 12 kgs, in which 4 kg is of skeletal muscle, right? Skeletal muscle, and 8 kg is of non-skeletal muscle protein, right? Which also include visceral protein, right? So intracellular water is basically 42 kgs, and 2/3 is intracellular, that is 28 kgs, and extracellular water is 1/3, that is 14 kg. Total 42 kgs of water is there in a 70 kg average meal, and out of which 3 kg are of minerals, and they are basically more common in the most commonly found in the bone, right? So this is the basically a composition of a normal human body of a normal 70 kg person. So just remember the lean body mass. Lean body mass doesn't contain fat, and just remember that protein is divided into 2 parts. One is skeletal muscle of 4 kg, and non-skeletal muscle is of 2/3 of protein, that is which also contain the visceral protein. So now moving on to next slide. Just remember that primary labile energy reserve is fat, energy reserve, right? Whereas primary labile protein is skeletal muscle, right? So just remember that primary labile energy reserve is fat and primary labile protein reserve is skeletal muscle. And also please remember 1 gram of nitrogen is equivalent to 6.25 gram of protein, which is also equivalent to 36 gram of lean tissue. Lean tissue means tissue which doesn't contain fat, right? So 1 gram of nitrogen is equal to 36 gram of lean tissue. These are the huge comparisons. So now we have discussed about the normal composition. Now we are going to discuss about what changes happen in this body composition during a pathology or during an illness. So what happens in starvation? It is important to know that as soon as starvation starts, body undergo catabolism. So catabolism mean muscle wasting, weight loss, weight and protein loss, right? Very clear, right? So it is important to know that in starvation, adaptive changes sets in, right? So what they do, they decrease the rate of protein loss, they also decrease the rate of weight loss, right? So this is how the hunger strike can survive for 50 to 60 days because of adaptive changes. Guys, please just remember adaptive changes in the starvation, and this is a factor why the people are able to do total hunger strike for 50 to 60 days, because adaptive changes decrease the rate of protein loss and also decrease the rate of weight decline, right? So now we have discussed about the starvation. Now what happened in the body composition in the case of major injury or critical illness? It is important to know that adaptive changes doesn't happen here, right? So this leads to autocannibalism, right? There is a massive urinary nitrogen loss which is equal to 10 to 20 gram per day, which is equivalent to losing half kg of lean tissue per day. This is a huge amount, right? And it's important to know that once the protein mass is 30 to 40% of the total, then the survival is unlikely, right? So it is seen that we, as in the daily practice, we see that whenever patient comes after a major injury or critical illness, we start the resuscitation. So this resuscitation leads to expansion of extracellular water by 6 to 10 liter, right? Please remember this, guys. This expansion of extracellular water leads to weight gain, right? Please remember that in this condition, catabolism is happening, right? So the body is losing muscle and protein, right? But despite of that, weight gain is happening. Weight gain is happening because of resuscitation, right? So this is a paradox, right? But it is seen that at around 10th day, extracellular space expansion resolves and protein losses reaches 15%. At this point, weight declines start, right? Here also there was a loss of protein, there was loss of muscle, but because of extracellular water, weight gain happened. This was a paradox. But at around 10th day, this expansion resolves and protein losses reaches a very low point beyond which weight declines start. So these are beautiful diagrams given in the Bailey. So here we will understand that you can see this is basically a starvation curve, right? Here you can see that the phase between this and this is quite steep as compared to phase like this. Here the curve is getting flattened down. So why this is happening? At this point, adaptive changes are setting in, right? So remember this. Here adaptive changes are playing role. So after that, the decline of the weight, the curve has got flattened up. So this happened in the starvation. Whereas if we compare in the case of sepsis and multi-organ failure, here we can see that initially there is a weight gain, right? This is the period of weight gain. This is happening because of the initial resuscitation. But at the around 10th day, declines start, right? So this is happening in sepsis and multi-organ failure, right? So this diagram beautifully depicts both the conditions. So please remember this, guys. Catabolism lead to decrease in fat mass and skeletal muscle, but body weight may paradoxically increase because of expansion of extracellular fluid space. This is very important, and this will you can see the importance of line in your clinical practice. When you go to the ICU, you will going to find the patient whose weight will going to increase paradoxically despite having an intense catabolic phase. So this is a post-test. What is the primary labile energy reserve in the body? The answer is fat. What is the average weight of the fat in the 70 kg male? Answer is 13. 57 kg is a lean body mass, mass without fat. At what percentage of total protein does survival become unlikely? 30 to 40% is the answer. How much lean tissue is equivalent to the breakdown of 1 gram of nitrogen in urine? Answer is 36 gram of lean tissue. So now we're going to discuss about avoidable factors that compound the response to injury. So guys, here are the pre-test in this topic. Question number 1, what initiate the afferent nerve input to the CNS during the simple hemorrhage? Volume receptors in the carotid artery, pain receptors in the aortic arc, pressure receptors in the right atrium, pressure receptor in the carotid artery and the aortic arc, and volume receptor in the left atrium. Question number 2, in response of hemorrhage, what hormones are released through the efferent nerve input to the central nervous system? Insulin and cortisol, aldosterone and ADH, glucagon and thyroxine, and serotonin and melatonin. Question number 3, what is the consequence of hypothermia? Decreased adrenal steroid and catecholamines, increased postoperative cardiac arrhythmias, enhanced wound healing, none of the above. Question number 4, what is the purpose to protect the endothelium during the critical illness? Adequate nutrition, maintaining normal body temperature, maintaining normal glycemia with insulin infusion, none of the above. Question number 5, according to the modern anesthesia guidelines, what is the permissible time frame for clear fluid intake before surgery? Up to 4 hours before surgery, up to 1 hour, up to 2 hours before surgery, none of the above. Question number 7, what is the daily glucose requirement for sustaining cerebral energy metabolism during starvation? 50 gram, 80 gram, 100 gram and 120 gram. So now I am going to discuss about the text. So these are the factors, these are the avoidable factors that can compound the response to injury. Continuous hemorrhage and hypovolemia, hypothermia, tissue edema, tissue underperfusion, starvation and immobility, and anesthesia and severe psychological stress can also compound injury. So these are the factors which going to increase the metabolic response, and these all can be avoided, right? So here we can see the pathophysiology. The factors like hypothermia, hypotension and pain leads to activation of adrenosympathetic activation, and also it leads to cytokine cascade release. So because of both of these, there is a pyrexia, acute phase response, insulin resistance and muscle protein degradation. So all these are part of the catabolism. Basically, ultimately, all these factors are leading to catabolism. It is seen that immobilization and starvation also causes catabolism. So the number 1 factor I am going to discuss about volume loss, which could also be a hemorrhage. So hemorrhage basically activate the pressure receptors of the carotid artery and the aortic arch, and also activate the volume receptor of left atrium. This leads to aldosterone and ADH release, and what these hormones do? These hormones result into extracellular water and salt conservation or retention, right? So extracellular water and salt conservation, it is important to know that a saline resuscitation, which is very commonly done in clinical practice in some places, can augment this conservation or retention. So this can make the situation bad. Saline resuscitation can lead to more water and salt conservation and can compound the injury. So this retention of water and salt lead to peripheral and visceral edema, which affect the gastric function. We basically delayed the gastric emptying, and this peripheral and visceral edema also delay the recovery and prolong the hospital stay. So guys, this is a very important point. We should know what IV fluid to choose for resuscitation, because choosing a wrong IV fluid can compound the injury, right? It can compound the edema, which can delay the overall recovery and prolong the hospital stay. So the next factor, a vital factor, is hypothermia. So what do hypothermia do? Hypothermia increases the adrenal steroid and catecholamines, and it also increases the post-operative cardiac arrhythmias and also increases the catabolism. So normothermia decreases wound infection, bleeding and cardiac complication. So how does the tissue edema compounds the injury? So it is seen that in case of inflammation and injury, there is a vasodilation or increased capillary permeability, and this is caused by cytokines, prostanoid, bradykinin, and nitric oxide, and this increased vasodilation or increased capillary permeability leads to exit of fluid, protein, leukocyte, macrophages, and electrolyte from the vascular space, and this leads to tissue edema, right? This leads to this extravasation lead to tissue edema, and this leads to impaired alveolar oxygen diffusion and decrease renal function, right? So this is a mechanism of tissue edema in case of inflammation and injury, and it is seen that vasodilation in tissue edema leads to decrease in the intravascular volume, and this can lead to shock if there is an inadequate resuscitation, and to compensate that, intracellular volume decreases so that it can partially replenish the intravascular and extracellular volume. So this is a very important point. Vasodilation in the tissue edema leads to decrease in the intravascular volume, and to compensate that, intracellular volume decreases and replenishes the intravascular and extracellular volume. So now the another factor is which is avoidable and can lead to increased response of injury, and that is systemic inflammation and tissue underperfusion. It is seen that vascular endothelium controls the vasomotor tone and the microvascular flow. Any excessive endothelial activation can lead to decrease in the flow and lead to increased hypoxia and increased risk of organ failure. So it is seen that normoglycemia protects the endothelium via inhibiting the nitric oxide release. Just remember this. So now one of the most important avoidable factor is starvation. This is very important topic. So what is happening in starvation? During starvation, the body need to generate 100 gram of glucose per day to sustain the cerebral metabolism. This is very important. So how this is achieved? In the first 24 hours, it is achieved by glycogenolysis, and thereafter by hepatoglycogenesis, which is from amino acid, glycerol, and lactate, right? As the starvation proceeds, the lean tissue loss rate decreases as the liver convert free fatty acid into the ketone bodies, right? This is very important, and this is the adaptive change I was talking previously. So as the starvation progresses, adaptive changes kick in, which is liver convert the free fatty acid into the ketone bodies. So the decline of the protein mass, decline of the skeletal mass get decreased. So it is seen that in starvation, the metabolism of other tissue is maintained by mobilizing the fat from the adipose tissue. And how this happens? This is dependent on the fall in the circulating insulin level. So guys, in this slide, I am going to discuss about surgical perioperative NPO. This is a very important slide because in our daily clinical practice, we tell the patient to be kept NPO from the midnight just before the day of surgery, and also we keep the patient NPO after the surgery for a variable amount of time, which depend on the type of surgery we have performed. But it is very important to know that the surgical perioperative NPO is a kind of a starvation. So all the negative effect of starvation will happen in this stage also. So it is very important to avoid unnecessary fasting in the first instance, and we can allow the patient orally early, right? And in some cases, we can allow also parenteral nutrition. So it going to attenuate the side effect of starvation. So it is seen that 2 liters of IV fluid of 4% dextrose and 0.1% sodium chloride as a maintenance IV fluid can provide 80 grams of glucose per day and has a significant protein sparing effect, right? So what does the modern guidelines say? So modern guidelines of anesthesia were made to decrease the negative impact of the NPO. So they say that we can allow the intake of clear liquid up to 2 hours before the surgery. So this is a very important point. No need to keep the patient NPO from midnight. You can allow the intake of clear fluid up to 2 hours before the surgery. Second important point is that administration of a carbohydrate drink at this time reduces the perioperative anxiety and thirst, and also decreases the post-operative insulin resistance. So this is a very important point. We can allow the intake of clear liquid up to 2 hours before surgery, and the carbohydrate drink is the best form of the liquid to be given before the surgery, as it reduces the anxiety and also decreases the post-operative insulin resistance. This is a very important slide, and this you can apply in your clinical practice also. So the next factor is immobility. So basically, immobility induces the muscle wasting. So it impairs the normal meal-derived amino acid stimulation of the protein synthesis in skeletal muscle. That is why we tell the patient for early mobilization and decrease bed rest, right? Decrease bed rest and early mobilization. So these are very important to prevent the muscle wasting. So now the post-test answer of the question number 1 is pressure receptor in the carotid artery and the aortic arc and the volume receptor in the left atrium initiate the efferent nerve input to the CNS during simple hemorrhage. Answer of the question number 2 is aldosterone and ADH are released in response to hemorrhage. Answer of the question number 3 is B. So consequence of hypothermia is increased postoperative cardiac arrhythmia. Basically decrease the wound healing, and it also increase the production of the steroid and catecholamine. So correct answer is choice number B. So question number 5. According to the modern anesthesia, what is the permissible time before for clear fluid intake before surgery? The answer is up to 2 hours before surgery. Question number 7. What is the daily glucose requirement for sustaining cerebral energy metabolism during starvation? Answer is 100 grams. So now the last topic of the day is ERAs, enhanced recovery after surgery, right? So these are the pre-tests. How beta blockers and statin causes improvement in long-term survival after the major injury. It suppresses the adaptive immunity. It activates the innate immunity. It suppresses the innate immunity at the time of surgery, and none of the above. Question number 2, which is not a part of ERAS protocol, minimal access technique, early mobilization, use of statin and beta blockers perioperatively, and early start of anticoagulant after the surgery. So what are the steps for ERAS? So it is important to know that all this step leads to decreased metabolic response, right? Remember this. The purpose of this step is to decrease the metabolic response to injury and also to induce minimum injury, right? Just remember these 2 points. So these are minimal access technique, like doing a laparoscopic surgery will lead to enhanced recovery. It is important to know that any effort to block the painful stimuli, which could be in the form of epidural analgesia, spinal analgesia, or patient control analgesia, will lead to reduced cortisol surge and decreased insulin resistance. So obviously inflammatory impact will be less, the metabolic response will be less. Statin and beta blockers basically decrease the innate immune response after the major surgery, and that is why they help in long-term survival after the major surgery. So this is the mechanism of statin and beta blockers. It is also important that if we keep the starvation period minimal, it will lead to decreased metabolic response and it will lead to enhanced recovery, right? And early mobilization is also very important for enhanced recovery after the surgery. So guys, remember these points. Basically, minimal access technique, blockade of afferent painful stimuli, statin beta blockers, minimal period of starvation, and early mobilization is very important for enhanced recovery after the surgery. And all these measures reduces the metabolic response or causes minimal injury in the first place. So a one-shot spinal diamorphine and or a 6-12-hour infusion of IV lidocaine is basically have a opioid sparing effect, and it also enhances the gut function and overall recovery. So this is a kind of a ideal analgesia for enhanced recovery, right? Just remember this, please. Ideal analgesia, right? So here we can see there is a graph which shows a difference between the traditional care and ERAS intervention. Here we can see that the dip in the functional status is more in the case of traditional care. Dip is like this. the dip in the functional capacity is much more in traditional care as compared to dip in the ERAS protocol. And it is also very important to know that the patient has recovered his functional capacity in a short period of time as compared to traditional care. Traditional care, it has taken much more time as compared to in the ERAS protocol. So both the things, it is important to know that there are two things happening here. The overall dip in the functional capacity is more in the traditional care as compared to ERAS intervention. Second thing is recovery or coming back to the preoperative functional status is much faster in the ERAS intervention as compared to the traditional care. So these are the post tests. The answer of the question number 1 is basically choice number C, suppression of innate immunity at the time of surgery. This is a mechanism of beta blocker and statin which causes improvement in the long-term survival after the major surgery. And early start of the anticoagulant after the surgery is not a part of a ERAS protocol, right? Thank you so much. I hope you enjoyed the lecture, and you can connect me on these following contact details if you have any doubts, and I will be happy to address them. Now the session is open for question and answer.